Interesting topic on echocardiography, that is a direct visualization of coronary arteries. Direct means that you can see the coronary arteries on echocardiography. I think it's a good idea to subscribe, because if you subscribe this channel you would be able to know that when I'm posting the new video for you guys. In this topic I'm going to discuss coronary artery visualization in the fetal circulation, in the pediatric heart, as well as in adults when you are looking for a coronary artery disease, in a fetal and pediatric for congenital heart disease or a Kawasaki disease, in adult for more so in congenital plus in patients with atherosclerotic coronary artery disease. Can you see coronary arteries? Yes, we can see on echocardiography. The problem is that once we do a three-dimensional kind of orientation of the heart, we have various planes which are actually right angle to each other. These three orthogonal planes actually formulate all our views in echocardiography: short axis views, or long axis views, or a two-chamber view we can see on these views. Coronary arteries, they are three-dimensionally placed, so that means cannot be seen in a single plane of the echocardiography as compared to a single plane visualization of a coronary arteries, because they are superimposed head on when you're looking at a coronary angiogram. So you can see all coronary arteries in one go, whether you're doing a two-dimensional cath angiography or even a three-dimensional angiography, but you see the things in a single plane. But in echocardiography you have to move the probe, take the images in a piecemeal. It doesn't come as a holistic all coronary arteries together. So we have to step up echocardiography to see each segment of coronary artery disease separately and analyze it. You can use the same echocardiogram which you use for an adult, fetal or pediatric echo, but you need to optimize the images. That's very, very important. Coronary arteries are about 3 to 4 millimeter in an adult population. Seeing that with a flow which is markedly reduced than the rest of the LV and RV chambers, with a problem that the coronary arteries are on the myocardium, epicardial ones, and they move vigorously when the heart contracts or relaxes. So in all those situations, it puts a very difficult situation for us to make an assessment of coronary artery if you are trying to visualize it. So you have to optimize the image beautifully so that you get the best frame rate, you get the best color fill. And these are the ways which we can do that. I am going to take not all but a few of these which are irrelevant and important for coronary artery disease, and more so which are not commonly understood. Now, one is the dynamic range. Remember, dynamic range is a very important aspect once you're seeing the coronary arteries. Now, in the dynamic range, what it actually means is that in case you have a dynamic range which is low, let's say a 1-bit dynamic range, would actually differentiate the structures between what we visualize is between black and white. But as you increase the dynamic range, your visualization of various shades of gray improves. Now, in the coronary artery disease, this is the way you see the dynamic range, more of the gray shades. You see the texture of the liver, but what we are interested in a tissue and a fluid interface, like in coronary artery. So once you are trying to look for an interface, you just need something like black and white or just closer to that. So reduce the Nyquist limit to minimum possible so that you get a good tissue and fluid interface, and you are not really interested in a characterization of the tissue. So that's why the dynamic range has to be on the lower side when you are performing coronary artery visualization. The next most important aspect, because the flows in the coronary artery are a slower speed. So once you are looking at a slower speed, something like less than 100 centimeters per second, you need to lower the Nyquist limit. The velocity scale has to be lower, something like less than 20 in a usual case of a coronary artery disease. Here you see the aorta, you see the right coronary artery, you see the right ventricle. This is a cross-section view. At the level of an aortic valve, you see a small pulmonary valve here as well. Now here you see the flow in the coronary artery, but this lot messed up because of the low neck wedge limit. Lot of blood flows, you are seeing this, and how to improve upon that, you see it on side by side color Doppler. And this, once you see on a side by side, you know which area you are interested in. This area is not superimposed by color, so this is for a reference. Now getting a side by side 2D with a color Doppler does not reduce the resolution of the machine or a frame rate, so you don't lose anything by seeing structures side by side. For example, in this case, if I show you by side, when you see the coronary artery here, you see the represented color Doppler on this side, and you see the red color, and that's how it becomes good to see the coronary artery flow again under the mess of low velocity range, lot of colored flow. Next more important thing which I think you should all know is that increase the line density. These are less traveled roads. A lot of people do not know about it, but I'm spending a bit of time here. Line density, the packet size, and the ensemble. Now line density is that you increase the number of scanning lines in that small segment of the color Doppler, and if you increase the number of lines, computation takes little slower. There is a drop of the frame rate if you increase. So if there is a drop of frame rate, what you're supposed to do is make the size of the color box smaller. So in the smaller, then you try to increase the frame rate. Now what you see here, the second one is the packet size. You improve the sample size of the color Doppler. Like in pulse Doppler, you can increase the sample volume. Here also you can increase the sample volume. Obviously this would come at the cost of drop in the frame rate, but you would get a better fill of the color in the system. Then increased ensemble. What is ensemble? Ensemble is number of beats, number of the ultrasound wavelengths sent in one packet. So ensemble is a packet of ultrasound beam sent. Ultrasound beam is always sent in packets, not as a single frequency drop. So this is, if you have a larger train of samples, the waveforms sent, you would have a longer ensemble. Higher would be the resolution, lower would be the frame rate. But if you increase ensemble, the colorful fill would become beautiful. Another thing which is not commonly appreciated is the balance. You see always a gray bar along with this bar of a color Doppler. This gray bar represents what? You always see it and you don't actually know why this is there. This is because this indicates that this line here indicates that you're giving more priority to the 2D. Here you are giving less priority to the 2D. So whenever the color Doppler image, I'm going to show you an example. Now look at this carotid Doppler. There's a lot of fill. You see under the background there was a 2D noise over which, because we gave a priority to the color Doppler to be shown on the screen. So now the color Doppler overrides the 2D information in the background. If we give priority to the 2D then to the color, you see lot of 2D information mixing with the color and not giving an adequate fill. So balance setting has to be on the maximum size, that you give the maximum priority to the color Doppler in the coronary artery disease. Otherwise, by the movement of the coronary arteries, you would get a lot of artifacts there. The next is to increase the smoothness. That means that you increase the in between, you have an increased persistence. Color Doppler persists, information of one image persists for a couple of milliseconds, so that you get a little smoother image when you see a coronary artery. In a couple of machines like mine, this is Philips, you do have a coronary preset. You can always go and choose that coronary preset where all these parameters have been already set. So now this is how I do it. You can take a screenshot of this busy slide. You see that all these parameters which I set when I want to see a coronary arteries in an equipment. You can use an X-plane. The advantage of X-plane is that if you see a coronary artery in the cross section, you on a 3D probe, you see the 90-degree of side by side, where you see the coronary artery in a longitudinal format, and this is how actually you see the X-plane on a 3D. You see a simultaneously 90-degree plane, orthogonal plane. Despite all that, direct visualization of coronary artery is not 100%. In the proximal part, LAD, LCX, circumflex, the success rate is good. Circumflex, you only pick up a third of patients. Circumflex is a smaller artery. It goes posteriorly and it's not very clearly visualized. If we talk about looking at more than one segment, if you want to see all the segments of circumflex artery, the chances are that you are not successful in majority of the patient to see all three segments. Segments meaning proximal, mid and distal. In an LAD, you are able to successfully see all the three segments in only 2/3 of patients and not beyond. Let us see each segment separately. Left main, proximal LAD, proximal RCA and circumflex, and the view what we have is a parasternal short axis view at the aortic valve level. You angle it, tilt it slightly cranially. You see the left coronary artery, you see the left circumflex here. This is the left coronary artery, this is left main, this is LAD, and that's the circumflex, and that is the origin of the right coronary artery. You see it here. Again, showing you a couple of videos of right coronary artery, which comes somewhere around 11 o'clock position in this short axis view at the aortic valve level. This is the pulmonary valve, this is the pulmonary artery, right atrium, and in between the right ventricle and right atrium, where you have an AV groove, you have this tissue or a fat. This is where you see the right coronary artery. When the left coronary artery is seen on the other side, this is a tissue between the RVOT and aorta and LA in the background. And if you see, this is the left coronary artery which goes across, that's the pulmonary valve which goes across the right RVOT and also across the pulmonary artery. So then this is the aorta. You can see the LAD in a color, and on a color Doppler of the aorta, this is a patient with a short left main. You see a left main, you see LAD, the flow coming towards the transducer represented as red flow, and away from the transducer represented as a blue flow in the circumflex. So left main bifurcates into LAD and the circumflex, and you can see both. The left main, let's say if you're interested to look at left main disease, if the left main is disease, the visualization of diseased left main or picking up the disease of the left main, the sensitivity is over 80%. So that's very important. If you're doing an echocardiogram, most of us would finish the echocardiogram by doing systolic functions, the diameter, the measurements, and the ejection fraction, and also the regional wall motion. But that's end of the story. We don't look at the coronaries. It's a good idea to look at the coronaries because it's going to prognosticate. Let's say if you have an 80% chance of picking up a left main disease, it makes a lot of sense that you can be cautioned. Maybe you do not perform a stress echo on this patient it was planned for, or a TMT, because if you have a left main, the chances are that you are going to have a crash problem. And left main again puts you into an area where you need a higher quicker need of a coronary angiography rather than in a casual format. Now this is a apical 5-chamber view. This is aorta, then this is left coronary artery, the right coronary artery on the other side. So that was proximal. Let's talk about the mid-segment coronary arteries. Mid-segment coronary arteries, you have to have couple of views. For LAD, you have to go a little more cranially, where you see the RVOT, and you can see it crossing the RVOT. Circumflex is, and the mid-segment is pretty difficult to see. You need a lot of angulations to see that. That usually is seen on a cross-sectional view of the left ventricle. Let's see the circumflex artery. This is the patient which I am going to show you as a case report later. You see the left circumflex artery, and you see this calcification of the left coronary artery, and if you see the blood flow, this is going in the AV groove posteriorly. And this circumflex artery, you can see this is the left dominant circulation. You can see there is aliasing there, increase in flow, aliasing. That's with this, the Nyquist limit is 75 centimeter per second. And I must remind you here, the color Doppler uses median velocity, mean velocity. It does not use the peak velocity. So whatever you see on the color here is the mean velocity. Obviously the peak velocity is higher than this. And then you can see OMs or anterior marginal branches of a right coronary artery crossing across the right ventricle. Let me show you the LAD, proximal, mid and distal. Now this is an LAD, this is the RVOT, this is the short axis view at the level of little angled at the level of aortic valve. That's the pulmonary valve, that's the pulmonary artery, and you see this is the coronary artery. This is the proximal part of the LAD, what you see here. Along with that, you see the blue color also coming, and that accompanying coronary vein. You see the coronary artery again in the mid segment, and you see an associated coronary vein with the blue color. Coronary artery at the apical view, where you see this is close to the apex. Again you see a coronary artery with accompanying vein which is in blue color, and LAD distal is in the red color. So that's again right close to the apex, and you see the LAD crossing the apex and going into the right ventricle. So this is the apical view of the LAD. You can actually see the flow, you can see the hyperemia by giving various drugs on the coronary artery flow. A lot of studies been done, and the coronary artery has forward systolic and diastolic flow. The main flow in the coronary artery is in diastole, lesser in the systole, and this ratio is very, very important to rule out a proximal coronary artery obstruction. Intramural coronary arteries, you have a systolic reversal and only the diastolic flow. How do you visualize the coronary arteries on echo in a distal LAD and PAD? I have already showed you. Let me show you. We might be lucky occasionally. You have a pericardial effusion, and then you have a fluid around the heart, which gives you a very nice kind of contrast or a background to look at the coronary arteries. And this is the posterior descending coronary artery running in the interventricular groove. Here you see the coronary sinus. That means you are on the posterior aspect of the left ventricle and the right ventricle. This in the AV groove is a posterior descending artery, so nicely seen because there was a pericardial effusion. So in the pericardial effusion, you see the coronary arteries in a very nice way because of the fluid. That is the left circumflex artery, which is represented as a circle in atrioventricular groove along the left atrium and the left ventricle. Then you have again a small thin coronary arteries, which are also seen very nicely because of the pericardial effusion, and that's again the same posterior descending artery seen nicely in a whole length. Then another situation where the problem can happen is that when you have a hypertrophied cardiomyopathy, this is a zoomed view of the left ventricle hypertrophy. Look at this. This is aorta, the aortic valve. Then you have this is the mitral valve, the LV, and then you have this thick interventricular septum. Just there are three main coronary arteries which are there, which are the septal branches, and in case you're planning to do a septal ablation, you got to be careful that this patient might require injection in 3 arteries because there are all 3 which are big. So that's an important decision which can be made on visualizing the coronary artery. Can I see the coronary artery in the fetus? Of course I can. Remember, the size of the fetus at 20 weeks is about size of an almond, and you seeing a coronary artery is a bit of a challenge, and then if you zoom it you can see it. But remember, if you see a coronary artery and a coronary artery flow in the fetus, that actually indicates the coronary arteries are dilated. Okay, normal coronary arteries are not possible to be seen on the fetal echo. Visualization of the posterior descending artery, that you actually look at from the 2-chamber view, the LV and the aorta, and that's where you see the posterior descending artery in the posterior interventricular groove, and that was the patient of L kappa. We had a markedly increased flow there, and that's why you could see aliasing in a very long length of the posterior descending artery. A normal posterior descending artery on a color Doppler is fairly difficult to visualize, being it's a small artery. Coronary artery mimics. Now in here, if you notice, you would think that this is a coronary artery but one clue is that the blood flow is again away from the transducer. So coronary artery, left coronary artery, you expected a flow towards the apex, but that's not happening. This gives you me a clue that it may not be a coronary artery, or there is an obstruction of proximal LAD giving a reversal of flow. But then it may not be a coronary artery when I move my probe, slightly angle it, and then what you see is that this is a part of the trabeculations of the left ventricle in a patient where there was a non-compaction, and one of the trabecular space was looking like as if there was a coronary artery. In the coronary artery in a short axis view, you see these 2 coronary arteries, but you see a space which is a pericardial space behind the aorta, right? So this is a space which should not be mistaken for coronary artery. Many a time a similar atrioventricular groove, pericardial reflection can give this kind of a tram-like structure, which you think this is a coronary artery, but it's an artifact. And this you can see there is quite glistening shadows. This is hyperechogenicity making it a tram-like. This is not a true right or a left coronary artery in atrioventricular groove. This is an artifact. So guys, this was the first of visualization, the normal patients. Next I'm going to do in patients, those who are cases where there was abnormalities right from the fetus, pediatric and adult population. So good idea to subscribe so that the next time when I put the next part 2 of this video, you would be immediately notified. Bye till then, and happy learning.